Mm-hmm. Now, like I told you about the Med Bpard again, right? Mm-hmm. All right. The patient is 24 years old, active duty member, who fell 3 stories onto the pavement the day of admission. The patient landed feet first and fell on to his left side, right? He was admitted and cleared by general surgery for his abdomen and cervical spine. He was admitted to the orthopedic service with a complaint of sacral and low back pain. The patient was diagnosed with x-ray and physical examination to have a vertical shear component complex pelvis fracture with elevation of the left hemipelvis approximately 0.5 to 1 full centimeter, right? Now, in our language, that's about 1/4 of an inch to 1/2 an inch, right? And maybe 5/3, right? Somewhere there, right? The patient also had a large pelvic intraperitoneal hematoma within which was stable. The patient was taken to the operating room the day of admission, where he underwent closed reduction and placement of external fixation device on his pelvis. Post-operative x-rays confirmed maintenance of his reduction. He was admitted to the ward where he was kept in skeletal traction. It was noted during the operation that the patient also had a left collarbone fracture and lateral ligament disruption. The patient had an arthrotomy performed, irrigation and debridement of the ankle joint and primary closure. The patient was placed into a short leg cast post-operatively, right, once the swelling went down. And his splint was removed, right. The patient was kept in skeletal traction for approximately 4 weeks, and the traction was discharged after x-rays were taken. 1 week post removal of the traction, the x-rays were retaken and showed that there was minimum increase in the change in the elevation of the pelvis, right? Minimum increase, right? The patient was undergoing bed-to-chair transfer, and at the point that the x-rays were noted to be stable, he was proceeding to toe touch only weight bearing on the left side, right? The patient had done well in physical therapy with toe touch weight bearing, right? And it is planned for him to be advanced to removal of the external fixation device at the 6th to 8th week point. Post-operatively, the patient will be taken out of his short leg cast at the 6th week point as well, and placed into a gel splint to allow range of motion exercises, right? And still maintain support to the lateral collateral ligaments. Complex pelvis fracture with vertical shear component of the left hemipelvis, right? Grade 3 ankle sprain with osteochondra defect of the talar dome. And I get some numbers, 84300 and then 7388. It is the opinion of the medical board that the nature or patients, maybe, I know. It's kind of spelled wrong. Yeah, patients. Medical conditions interferes with the reasonable performance of assigned duties. On that basis, this case is referred to the Physical Evaluation Board for fitness for duty determination, right? It is recommended that pending disposition that the patient continue with his inpatient care and progress towards outpatient care, which he will be able to continue through the VA system, right? Right. So I was getting out of bed and I was doing what's called toe touch with the walker. All right. Now, when I went on convalescent leave, I was on crutches, right? And the rest of it is the people who signed it. Now, Bukta, I guess, is the bi-direction, right? I mean, it's on the K. Right. And, of course, it's got signatures, right? And, like I said, you see theirs, mine, and the witnesses, right? Exactly. And people don't normally think that anyway. Now, this was before I was seen, right, by the Navy for mental problems, but Dr. Ann Weinrep, said I was psychologically fit for naval duty. And and even wrote a letter, right, for me, right, saying James Lee was seen by me in 1990. At that time, he did not exhibit any delusions, religious or other, hallucinations, or any psychotic process symptoms. His thought process and associations were logical, coherent, and goal-oriented. Although the MCMI is not the best instrument for measuring schizophrenia, it does measure current psychotic process. The MCMI confirmed my assessment that there was no evidence of psychotic or delusional symptoms, right? Furthermore, the case was discussed with our psychiatrist, who did not detect any psychotic symptomology, right? The likelihood of my having missed delusional or psychotic thinking is nil. That's another way of saying zero. I have worked many years with acute and chronic schizophrenics, and in fact, ran a VA day training center for this population. It is my strong clinical belief that this patient was not exhibiting any symptoms of schizophrenia or psychosis during the time I saw him, right? Right. And if you look at the signatures here, right, you can tell the same person here signed here. Right. Now, I'm not trying to expose Dr. Weinrep, but someone is. Now, this is another diagnosis, right, from the Med Bpard after Dr. Weinrep wrote a letter for me and stuff like that, right? This was written in July 15th of 94 when I was being seen by Bethesda, right? I don't even remember seeing that letter, right? Right. Because I failed September 15th, 1994, right? Now, the Med Bpard itself wasn't written up that specific date, by the way. It was written up the 1st of December, and they even put 93, which is a mistake, right? That's a typo. Right. See, the signature here says 94. Hey. See. So it's a typo, right, though, right? 3-4, you know, right? Exactly, right. Now, the patient was admitted to the inpatient psychiatric unit on the ward status. He remained pleasant and cooperative, participating well in individual, group, and milieu psychotherapy. The patient denied hallucinations and had no psychotherapy and had no episodes of uncontrolled glossolalia, but has maintained a zealous religious preoccupation with delusional content. He showed the beginnings of insight and has, in his words, begun to sort out reality from religion, trying to discern legitimate religious experience